Assalamu alaikum. A very good afternoon to everyone. I'm Dr. Mehreen Farooq, consultant physician and associate professor of internal medicine at Lahore Medical and Dental College and Ghurki Trust Teaching Hospital. I will be moderating today's session. On behalf of Pakistan Society of Internal Medicine, I heartily welcome the chair of the session, speakers, senior panelists, and the participants of today's session of Online Hypertension Course 2021. Today, we have two very informative talks by very brilliant professionals on two very important topics. Before going to that, I would like to introduce the chair of today's session. The chair of today's session is a nationally and internationally acclaimed physician, Professor Dr. Akbar Chaudhry, who's a graduate of Nishtar Medical College, did his post-graduation from United Kingdom. But he returned to Lahore, Pakistan to fulfill his passion of not only mentoring the undergraduate and postgraduate students, but also to bridge the gap between foreign post-graduation for Pakistani students, which he did successfully. He had been the principal and head of Department of Medicine for Fatma Jinnah Medical College, and currently he is heading the Department of Medicine and is also the principal of Azra Nahi Medical College. He has held many important positions internationally as well. He has been advisor of Royal College of Physicians, London, and advisor of World Health Organization. He has also been on the advisory board of Kumar and Clark Clinical Medicine 6th edition. With the time constraints of the session, I can't do justice in highlighting his achievements for the field of medicine. I would conclude by saying that his contributions for the medical education and improvement of healthcare are colossal, and we are proud of you, sir. It is an immense pleasure and honor to welcome you, sir, as the chair of today's session. Before starting the academic session of today and inviting the first speaker, I would like to highlight few points. All the participants are requested to complete the pre and post test. All queries should be posted in the question and answer window, and they would be answered during the session. There would be a session of question and answers at the end of each talk, but due to limited time, every question cannot be entertained in that. Participants who are willing to ask questions by themselves can raise hand during the question and answer session, and they will be entertained. Speakers are requested to limit their talk to 25 minutes, and each speaker is also requested to take a pause after their opening statement for the pre-test to be run. Without further ado, I would like to introduce our first speaker for today's session. She's a graduate of King Edward Medical College, a young, brilliant, energetic, and dynamic physician, Dr. Somia Iqtidar, who has been laureled both nationally and internationally for her professional excellence and dedication. She is currently working as Associate Professor of Medicine at King Edward Medical University and Mayo Hospital, Lahore. I welcome you, Dr. Somia. She's now going to talk and enlighten us on hypertension-mediated organ damage. Over to you, Somia.
Thank you very much, Dr. Mehreen, for your very kind words of introduction. Ladies and gentlemen, respected chair, panelists, and my worthy speaker, Professor Thomas Unger, a very good afternoon to all of you. Today we are going to talk about, you all know, hypertension. But before I start my talk, let me take you all back to the history. This is somewhere in 1930s in China, where there was a huge flood in the Yangtze River, and about 400,000 people, they lost their precious lives. And again, the deadly water cyclone Bhola, which came in 1970 and took lives of about 3 million people in Bangladesh, nobody can forget. The mishaps carried on, and in 2004, you all remember the tsunami. So the tsunami also led to a considerable number of deaths. And I am correlating all of this with another killer, which is also a silent killer, which leads to many deaths all related to cardiovascular disease, especially due to heart and stroke. And this is the #1 killer around the world. The purpose of showing you these pictures of flood, tsunami, and cyclone was that the damage and the destruction that a simple thing like increase in the pressure of water or an earthquake or things like natural disasters lead to many precious lives. And similarly, the increase in the pressure in the arteries of a human body leads to destruction of different organs. And ladies and gentlemen, this is what we are going to talk to you about today. So hypertension, which is the #1 killer of the world, it leads to organ damage even before we have any symptoms. And I'm going to give you an overview about this hypertension mediated organ damage in my today's talk. I will be telling you what this hypertension mediated organ damage is, what are the specific aspects of assessment of HMOD. We will be talking specifically of the organs it affects, including brain, kidney, heart, and arteries, and eyes. Then how we assess and detect this hypertension-mediated organ damage. And I will conclude by a few salient features, giving you a quick recap of what we have learned today. So by definition, hypertension-mediated organ damage is structural or functional alteration.
Soumya, you need to stop for the question.
Pause for the pre-test.
Oh, sorry. Oh, we can run the pretest now? Do I need to answer? Okay. Okay, I think we are done with the pretest. So
yes, we are done with that. Yes, now you can start your presentation.
So just to define what hypertension-mediated organ damage is, it is the structural or functional alteration of the arterial vasculature or organs that it supplies, and it is caused by the elevation in the blood pressure. The organs which are damaged by hypertension, they include brain, heart, kidneys, your central and peripheral arteries, and also your eyes. Talking about hypertension, the first word that comes to our mind is the cardiovascular problem. So the cardiovascular risk increases when the patients, they are hypertensive. And if they have hypertension-mediated organ damage, the effect multiplies. So some types of hypertension-mediated organ damage can be reversed by the treatment of hypertension and by giving antihypertensive drugs, especially when they are used early and the patient's levels are under control. But with long-standing hypertension, the hypertension-mediated organ damage may become irreversible despite improved blood pressure control. So in the initial stage or stage 1, if we start early on with the assessment of hypertensive-mediated organ damage and control the blood pressure levels within the range and keep them low, then we can be saved from many of the complications related to hypertension. In the stage 2 of hypertension, the hypertensive-mediated organ damage, it ensues, and it is visible by investigating the patient. And the hypertensive-mediated organ damage includes its effects on the heart, on kidneys, on arteries, on eyes, and this can be determined by measuring the left ventricular hypertrophy, by checking the presence of albumin in the urine, by doing tests for arterial stiffness, by looking at the eyes of the patients through fundoscopy and checking for retinopathy, and to assess the atherosclerosis. And at the stage 3, when this hypertensive-mediated organ damage continues, then it leads to the cardiovascular events that might be in the form of death, stroke, or myocardial infarction, or affecting the kidneys or heart, leading to their failure. So while the assessment of overall cardiovascular risk is important for the management of hypertension, additional detection of hypertension-mediated organ damage is unlikely to change the management of the patients who have already identified as high risk. And when I say high-risk patients, that means the patients who have an established cardiovascular disease, who've already had stroke, who are diabetic, who are suffering from chronic kidney disease, or familiar hypercholesterolemia. But the cardiovascular risk assessment can provide important therapeutic guidance on management for hypertensive patients with low or moderate overall risk through reclassification due to presence of hypertension-mediated organ damage. And this also helps in the prevention selection of drug treatment based on the specific impact of hypertension-mediated organ damage. So just to give you an idea, what is the risk of hypertension-mediated organ damage with staging of hypertension? I'm sharing with you this graph, which says that if in stage 1, which is uncomplicated hypertension, and there are no other risk factors, and your blood pressure is in stage 1 or high normal, then you have a very, very low risk. But as the grade of the hypertension increases, the risk also starts increases, which becomes moderate risk in grade 2 hypertension and severe or high risk in grade 3 hypertension. But if there are additional risk factors of hypertension mediated organ damage, like if there are 1 or 2 risk factors, this is further enhanced. And if there are more than 3 risk factors, then even in the grade 1 of hypertension, there is moderate to high risk to the patient. Similarly, in stage 2, if the patients have CKD or diabetes or hypertension-mediated organ damage, then even when he is having a high normal blood pressure or a grade 1 hypertension, the risk is very, very high. And obviously, as you advance in the staging of the hypertension, even at a high normal risk, and if you have established cardiovascular disease or CKD grade 4 or above, or you are diabetic with organ damage, the risk becomes very, very high right from the start of hypertension and even before that stage, which is the pre-hypertension stage. So now we will be looking at what specific organs are damaged by hypertension and how can we assess them and how should we address them. So in the brain, which is the control center of the body and which is responsible for all planning and functioning of the body, the hypertension affects it in the form of mild issues or severe issues. So there can be problems with memory like dementia or cognitive impairment, but it can also lead to transient ischemic attacks and stroke. So the early subclinical changes, usually they can be only detected by magnetic resonance imaging, and it includes the white matter lesions. There could be silent microinfarcts, microbleeds, or brain atrophy. But in our clinical practice, because of the limited availability and cost issues, brain MRI is not recommended as a routine practice to all the patients with hypertension, but it should be considered in patients with neurological disturbances, those having a memory loss or cognitive decline for early detection of hypertension-mediated organ damage and its effect on the brain. When we talk about heart, which is the main thing which hypertension, diabetes, dyslipidemia, any disease you take off, and if your heart is damaged, then your outcome is the worst. So the heart assessment is done by conventionally by a 12-lead ECG, which is recommended for routine workup of patients with hypertension. And with the help of simple criteria like Sokolov-Lyon index, in which we calculate the left ventricular hypertrophy by looking at SV1 and RV5, which should be more than 35 millimeters, you can determine if the patient is suffering from left ventricular hypertrophy. There's also Cornell index and Cornell voltage duration product, which gives us an idea if patient has left ventricular hypertrophy. And this can be an early predictor of hypertension-mediated organ damage in the heart. But echocardiography is more sensitive, and it more accurately assesses the left ventricular hypertrophy and is considered as a gold standard. The sensitivity of ECG left ventricular hypertrophy is limited, but a two-dimensional transthoracic echocardiography is the best method to assess left ventricular hypertrophy. With the help of echocardiogram, we can determine the left ventricular mass index, which if more than 115 grams per meter square in males and more than 95 grams per meter square in females, gives us the idea of how badly the heart has hypertrophied because of the effect of high pressure due to hypertension. Then we can also have an idea about LV geometry, left atrial volume, left ventricular systolic and diastolic dysfunction, which all give us the overall picture of how our hearts are functioning and what is the damage done by the hypertension or high blood pressure. The third organ, which is also a very vital organ and which must be assessed when we are seeing any patient suffering from high blood pressure, are your kidneys. So kidneys problems lead to blood pressure and blood pressure leads to kidney problems. And this is a continuum of damage which goes on. So the kidney damage can either be a cause or a consequence of hypertension, and it is best assessed routinely by simple renal function parameters. Just need to check the serum creatinine and calculate the estimated GFR and the albumin-urea, which is a wonderful and a very simple test by just checking the presence of albumin in the urine, which can also be done by dipstick or in the early urine morning spot urine or by urinary albumin creatinine ratio, which can also give you a fair idea of the early damage to kidneys because of high blood pressure. So these are the tests which should be routinely used in patients who we need to assess for hypertension-mediated organ damage. I'm just giving you this classification for the goals of hypertension in patients with renal disease because this is a very, very hot topic and we keep on advocating whether the goals should be different in patients who have chronic kidney disease, in patients who have diabetes, in patients who have heart disease. So according to this classification, non-diabetic adults with chronic kidney disease should have a blood pressure of less than 140 millimeters systolic and less than 90 millimeters diastolic if they have no albuminuria. So normoalbuminuric, the target is less than 140 by 90. But if there is micro or macroalbuminuria, even in non-diabetic patients with chronic kidney disease and hypertension, the goal changes to less than 130 by 80 millimeters of mercury. In patients who are diabetic but without non-dialysis support, the goals are less than 140 by 90 if they do not have albuminuria. But again, if they have albuminuria, the goal is less than 130 by 80. The patients who have received a kidney transplant, who are kidney transplant recipients, again, we have to keep blood pressure under control and the targets are tougher. It's less than 130 systolic and less than 80 millimeters of diastolic. And patients of chronic kidney disease who are very old or elderly patients, that groups we give a little relaxation. And in these patients, we have a goal of less than 140 systolic and less than or equal to 90 diastolic. But the targets may differ after consideration of the other comorbidities like patients with diabetes, patients with heart disease, and other comorbidities associated with deterioration in the body functions. Let's come to the third or one of the most important organs, I say. Arteries is a network of vessels which supplies every nook and corner of our body. So if our arteries are damaged due to hypertension, then the blood supply to our vital organs, which includes our heart, brain, kidneys, and our peripheral vasculature, if that is impaired or hampered, then we are in trouble. So arterial hypertension-mediated organ damage is usually assessed in three areas. One is your carotid arteries, the other one is your main vessel, which is aorta, and then the peripheral circulation is assessed by checking the lower extremity arteries. So when do you need to have an arterial assessment? Although there is evidence to indicate that all three, including your carotid, aorta, and lower extremity studies, add value beyond traditional risk factors, but their routine use is again currently not recommended unless and until they are clinically indicated. And they are clinically indicated in patients who develop neurological symptoms. Obviously, would like to have a look at their carotid arteries to see the blood supply to the brain is adequate or not. If patients have isolated systolic hypertension, in which cases you study their aorta, and suspected peripheral arterial disease, patients coming with poor perfusion and leg pains or claudication. In these patients, you have suspected peripheral artery disease and you check for lower extremity circulation. And how do we do that? Let's have a look about it. For the carotid arteries, you do a carotid ultrasound to detect the atherosclerotic plaque burden or stenosis And this is done by the intima media thickness, which we determine on the carotid Doppler ultrasound. For aorta, we check for vascular stiffness. And this vascular stiffness is done by the carotid femoral pulse wave velocity assessment, which is used to detect large artery stiffening, and we call it as PWV, which is the pulse wave velocity, which gives us a fair idea about the arterial stiffness specifically of the large artery like aorta. For the peripheral arterials or lower extremity assessment, the ankle brachial index is used. The Doppler ultrasound amplifies the sound of arterial blood flow by putting on a blood pressure recorded in the brachial artery. Then you see for sound of arterial blood flow located at the ankle, and pressure is recorded on the arteries of the ankle, and then they are compared. So we have a criteria to determine what is the extent of the peripheral arterial disease by looking at the ankle brachial index. Normally, it is between 1 to 1.4, and this is acceptable if it is more than 1. But if it starts coming down and it is between 0.8 to 0.9, then this value shows that there is some arterial disease. And in these patients, you treat the risk factors which are associated with peripheral arterial disease. But if the value starts dropping below 0.8 and it is in the range of 0.5 to 0.8, then this shows a moderate arterial disease, and you urgently need to refer to a vascular specialist to see what he can do about this peripheral arterial disease. But when the patients have severe peripheral arterial disease, the value of ankle brachial index is less than 0.5, and you urgently need to refer to a vascular surgeon or a vascular specialist to address this issue, because this can lead to loss of limbs as well. Coming on to the last but the most important thing in our human body through which we see the world, the eyes, which are also affected by the hypertension-mediated organ damage. I say that the eyes are the window to the body, and through looking through your eyes through a fundoscope gives you a lot of information, not only about hypertension, but so many other diseases. So the windows to the body, they are also affected by hypertension, and we can have a look at them by doing a fundoscopy. It is a simple clinical bedside test to screen for hypertensive retinopathy, and it is very important in hypertensive urgencies and emergencies, which Professor Sajid is going to cover in the next lecture, in which you can detect retinal hemorrhages, microaneurysms. People can have accelerated or malignant hypertension manifesting as papilledema. So just by looking at the fundus of these patients, you are able to evaluate these patients. Usually, the hypertensive retinopathy, it occurs in stage 2 of hypertension and above, but it should be performed in every patient with grade 2 hypertension, and it should be ideally done by an experienced examiner. And now also we have alternative techniques to visualize the fundus by digital fundus cameras, but they're usually not available in all the setups, and in only specialized centers they are available. So just to give you, I gave you an overview of how hypertension affects our different organs and what we can do to assess this hypertension. I'm not going into the details of the treatment, because this will be covered in the specific sections in the subsequent lectures when we will be talking about heart and hypertension, when we will be talking about renal dysfunction related to hypertension, when we will be talking about eye in the next few lectures. But I am going to give you a broad overview about consolidated guidelines which were published in European Society of Hypertension and European Society of Cardiology meeting in 2018, and which are very, very helpful in assessing the hypertension-mediated organ damage. So these guidelines or recommendations they share that the blood pressure lowering drug treatment should be started in patients on stage 2 or 3 hypertension at any level of cardiovascular risk, simultaneously with lifestyle intervention. But in patients with grade 1 hypertension, lifestyle interventions are the first step, and they are recommended to try to normalize BP. patients who have an addition, low or moderate risk, but there is no evidence of hypertension-mediated organ damage, blood pressure lowering drug treatment is recommended only if the lifestyle interventions are insufficient to normalize your blood pressure. And the recommendation is grade 1A. If the patients are at high risk and they have an evidence of hypertension-mediated organ damage, but they are of grade 1 hypertension, then prompt initiation of drug treatment is recommended simultaneously with lifestyle intervention. If patients are fit, but they are old age, then the treatment in the form of antihypertensive drugs are recommended only when systolic blood pressure is more than 160 millimeters of mercury. Antihypertensive treatment and lifestyle intervention are recommended for older patients more than 65 but less than 80 years when systolic blood pressure is in the grade 1 range, provided the treatment is well tolerated. If the blood pressure lowering treatment if of frail older patients is tolerated, then you can also start treatment in them. If the treatment is well tolerated, it should not be withdrawn only on the basis of age, even for patients who are very old or more than 80 years of age. And in patients with high or normal blood pressure, which is 130 to 139 systolic and 85 to 89 diastolic, you usually recommend only lifestyle changes. And patients may be considered when their cardiovascular risk is very high due to previous cardiovascular events, especially coronary artery disease, for starting antihypertensive treatment. The ESC and ESH hypertension guidelines 2018 also give us the recommendations about the clinical evaluation and assessment of hypertension-mediated organ damage. So about the kidneys, it says that the measurement of serum creatinine and eGFR is recommended in all hypertensive patients. And this is class 1 level B recommendation. The measurements of urine albumin creatinine ratio is also recommended in all hypertensive patients. And this is again class 1 B recommendation. But in selective patients, renal ultrasound and Doppler examination should be considered, especially in patients who have impaired renal function or who have suspected secondary hypertension along with albuminuria. And this is class 2AC level of recommendation. So the initial two tests, that is the serum creatinine and eGFR and urine albumin creatinine ratio, is a must for clinical evaluation and hypertension-mediated organ damage in all patients. Fundoscopy is recommended in patients with grade 2 or grade 3 hypertension and in all hypertensive patients who also have diabetes. And this is a class 1 level C recommendation. It may be considered in other hypertensive patients as well, but it's essential to be carried out in stage 2 or 3 hypertension, and especially patients who have diabetes along with hypertension. Regarding brain, in hypertension, usually we do not prescribe a brain MRI or CT, but in patients who have neurological symptoms, who have memory loss, who have TIAs or a cognitive decline, then you should go for an MRI for detecting brain infarctions, microbleeds, and this is also very helpful in early assessment of neurological damage due to hypertension. So I would just conclude my talk over here and just give you some take-home message, which is that the basic screening for hypertension-mediated organ damage is for your heart, your kidneys, and your eyes, and in selective cases for your brain and peripheral arteries. So a 12-lead ECG should be done to screen for left ventricular hypertrophy and other cardiac abnormalities, for example, cardiac arrhythmias, and it should be done in all patients in which you are screening for hypertension-mediated organ damage. Urine albumin creatinine ratio is done to detect elevations in the albumin excretion, and this is an early indicator of possible renal disease and should be frequently prescribed whenever you are screening the patients of hypertension for hypertension-mediated organ damage. Blood urea creatinine and eGFR, they also help us in detecting the possible renal disease and should be prescribed in patients of hypertension. Fundoscopy to detect hypertensive retinopathy, especially in patients with grade 2 or 3 hypertension or patients who are diabetic as well as hypertensive, should be routinely done. More detailed screening is required in a small set of patients. Echocardiography when LVH is suspected on ECG to confirm your diagnosis and to have better decisions. A carotid ultrasound to determine the presence of carotid plaques or stenosis, especially in patients with cerebrovascular disease or vascular disease elsewhere. You can also go for an abdominal ultrasound and Doppler studies to evaluate the renal size and structure, to exclude other renal problems like urinary tract obstruction or possible other underlying causes of CKD and hypertension, which can be fairly picked up on ultrasound and Doppler ultrasound. You evaluate the abdominal aorta for the evidence of aneurysmal dilatation and vascular disease. You can also examine the adrenal glands for adenoma or pheochromocytoma, which are the causes of secondary hypertension, and renal artery Doppler studies to screen for the presence of renovascular disease, especially in new and younger diabetics in the presence of asymmetrical renal size. Pulse wave velocity, which is an index of aortic stiffness and underlying arteriosclerosis, should also be done in those set of patients in which you want to see for the aorta. And ankle brachial index, which screen for the lower extremity arterial disease, is a very, very good and a bedside tool that can be used to assess the peripheral vasculature. In some people who have cognitive function and who are hypertensive, then you can have evaluation of cognition. And in patients who have some deterioration in their conscious level, or patients in which you have to evaluate for the presence of ischemic or hemorrhagic brain injury, or patients of having cerebrovascular disease, or who have memory loss or cognitive decline, brain imaging in the form of magnetic resonance images give us a very beautiful look at how the circulation of the brain is. So we also need to know what these markers of hypertension mediated organ damage, how sensitive they are to change, and how important it is to reproduce or interpret them, and at what time do they change, and what is the prognostic value of that change. So if we talk about heart, which we look through by ECG or echocardiogram by documenting the left ventricular hypertrophy, then the sensitivity to change by ECG is low, but by echocardiography is moderate. To reproduce and operator independence is high in left ventricular hypertrophy, but it is moderate in echocardiogram. The time to changes in both ECG and echocardiogram is about more than 6 months, so this is called moderate, and it has a prognostic value of the change. When we talk about the eGFR and urinary protein and excretion rate, then this is sensitivity to change is high for urinary protein excretion, but it is moderate for eGFR, and this is vice versa when we talk about the operator independence. The eGFR, it takes very slowly changes over years, but urinary protein excretion ratio, time to change is very fast, and it changes from weeks to months. And the prognostic value of the change for eGFR is very significant. The carotid intima media thickness, it is sensitivity to changes is very low. It is slowly changing, more than years are required to change it, and there's no prognostic value of the change. The pulse wave velocity by which we look at the aorta is a sensitivity to changes is high, and its time to changes is very fast, weeks to months, but we have very limited data to support the prognostic value of this change. Regarding the ankle brachial index, in which we assess the peripheral circulation, the sensitivity to change is low, and there is slow time to changes, and it takes months to change, and the prognostic value of this change is moderate. So thank you very much. With this, I will end my talk, not touching upon the treatment because I leave it to the speakers who will be covering each and every aspect of the hypertension affecting organs like kidneys, heart, eye, and brain in the lectures that you would be listening in our next few sessions. So thank you very much. If you have any questions, comments, or feedback, I would be more than happy to answer. Thank you.
Now to post-test. Now we go to the post-test.
Yeah.
And if we can have the comparative analysis later on, that would be good also. But if that may take some time by the IT, so we can go towards the
We can have the
discussion now.
question answer session at the moment till we get the comparison.
So while everyone is sort of looking into these questions that they would like to ask, I would just like to specially point out one thing over here for the audience and everyone. Thank you, Somia. As always, your talks are excellent and you come up with things that need to be pointed out. One thing that I need to sort of highlight over here is that when we talk of the ankle brachial index, it is basically with this presumption that one limb, which is your comparative limb, is the one which is normal. Thereby, the pressures that you are monitoring over there are the correct or the good pressures that you have. Because if the peripheral vascular disease is in all the limbs, then the ankle brachial index is not a reliable one. Another thing about the ankle brachial index is that this is a measure which is basically for the lower limbs, not for the upper limbs. So there are individuals who, for some reason, either because of a subclavian stenosis or because of a disease extending into their brachial artery, etc. So in them, the brachial pressures are actually less, and the pressures in the ankle are higher. So the ankle brachial index actually reverses over here. And this then becomes another way of looking at things. So ankle brachial index is something that is there with these two prerequisites that have to be assessed. Now, let's say if a person has got an advanced kind of a disease, then one has to accept the fact that other levels must be understood, because let's say if the person invasive blood pressure monitoring is saying 140, but his peripheral blood pressures all over are either not palpable at all or something like that. So it becomes a challenge in many, many ways in which you have to go for this thing. So ankle brachial index is an exceptional method. Nowadays, for your peripheral vascular disease, we are actually also relying a lot on the CT angiogram, the images that are available, and they are actually helpful in order to establish the kind of a disease pattern that may be there. And from there, we try and do both the pharmacological as well as the interventional treatment. These are the modalities that are extremely essential. One more thing regarding the kidneys, many a times actually the kidneys have an underlying structural disease lying over there, which is then the polycystic, the hydronephrotic, all of them are the ones which are already responsible for having the hypertension. So these many times are actually the secondary hypertensives, not the primary hypertensives. And then, of course, there are other things which are there, but as far as the organs and their damages are concerned, you're perfectly right. This all then leads to a whole set of problems. And since we're not at the moment discussing the management, so that becomes, and I think one of the questions actually that came up was regarding the management, which drugs to be used. So that is another thing. So if anyone else would like to add on.
I just did mention that the kidney disease could be a cause or a consequence of hypertension. So in the detailed assessment of hypertension-mediated organ damage, we must go for an ultrasound and a Doppler of kidneys to rule out secondary hypertension, polycystic kidney disease, any obstruction, and also look at the adrenals for pheochromocytoma. So this all needs to be done in the detailed assessment whenever you are suspected hypertension.
And one thing that a lot of you physicians are actually practicing it, especially in the teaching hospitals, and also a lot of them are also being done at the GP level where they have got their own small labs. But those who are doing this, I think a very, very basic dipstick analysis can help a physician at that very moment to decide whether a person has got albuminuria coming in the kidney or not. So it's a relatively inexpensive test. It costs you only about 10 or 15 rupees, whatever you may be charging. It's a different debate for it. And you can do a quick dipstick, ask the patient to go to the washroom, do a dipstick, and you have an answer within 30 seconds that it is there or not. Because many a times in our setup, the follow-ups are not adequate. And one of our biggest problem is that patients do not understand the severity of the disease. I think Tariq Saab has got his hand raised, so I will leave it to him now.
I mean, just to comment that it appears as if we are talking about peripheral vascular disease more than the hypertension alone. I mean, ankle break index is, of course, a very good tool to detect for early peripheral vascular disease, but there are other factors as well, and that may not be the only thing to look at. And a word about microalbuminuria. Now, albuminuria, it appears as if it is only for renal damage. No, it is a very sensitive tool to pick up early coronary artery disease as well. And there are studies which suggest that those having microalbuminuria, irrespective of any other risk factor like diabetes, they are at increased risk of having coronary events, and that's said as a good screening test for a possible occult coronary artery disease as well. So that's what I would probably be saying on. And then not to forget the extensive arteriosclerosis. The ankle break index would be super normal or more than 1.1 if it is vascular history is sclerotic rather than more, right? That also has to be kept into mind.
And another thing I think that we need to highlight over here again, and I'm just repeating it. I think you have already said that, but I'm just repeating it to highlight the issue that in hypertension, the main organ at risk is not the heart, it is your strokes. 2/3 of the patient of hypertension end up with stroke or something to do with the higher functions. While as far as the ischemic factor is concerned, atherosclerosis and all that, it's less than 50%. And even if you are having good pressures maintenance, yet there are chances, but of course, those chances really go down. So hypertension, the first thing that you should always be concerned about is a stroke, not the heart. And just for one thing, again, recapitulating about the ECG bit, why the ECG has sort of gone away from the fashion, it's basically because the chest size, the chest thickness makes a big difference as far as the voltage calibrations are concerned. A thin chest, a big heart, a thick chest, a small heart, all will have different voltages, while the echo is a direct measurement of the heart. And we have got now those assessments carried out. Therefore, the echo becomes a far more sensitive tool for assessing whether the heart is hypertrophied or not. And then you can do further as far as that is concerned.
Sorry, sir, to intervene. I would request the chair of the session to give his comments on the talk.
Thank you, Bilal, Marine, Soumya. I think it was a wonderful talk. Just to summarize and prove that, as you know, that hypertension is the commonest cardiovascular disease. So it's very common, 20% population, maybe after the age of 50, maybe 50% of the people are suffering. Well, that's why many people don't know about it, whether they have hypertension or not. And that is why we call it is a silent killer. So when we are treating these patients, so our assessing these patients is not only the manometric or the measurement of the blood pressure, but we also have to assess whether they have got associated other risk factors, whether they are diabetic, whether they have got hyperlipidemia, whether they are smokers, etc. So we have to, when we are evaluating these patients, we have to evaluate these patients as a whole. And apart from that, then we go to whether they have got an organ damage or the hypertension mediated organ damage. So we have to evaluate the heart, the brain, the eyes, kidneys, peripheral vessels, and then depending on that, actually, our priority will be which patient should be treated, which should be patient should be just left for some time with the lifestyle changes, and which patient should go straight to the treatment of the, and then we will be, I think, in next topic, we are going to discuss the which treatment should be given in certain particular groups, which medications would be more suitable. I think with that, I summarize, there should, and most of the things has been discussed by Professor Bilal Mahyuddin and Professor Tariq Wasim as well.
Thank you so much, sir. Can we have the comparison of the pre and post test run quickly so that we can go to the next talk?
I think most of the people already answered correctly, and the post tests we have even better results.
So thank you, Soumya, for the comment.
Next, please.
And the people have drifted more towards the lifestyle interventions and the need to do it. And the patients with other type A, etc., have actually lost, and all of them have started moving towards this fact. From 72, we have gone to 89. Really, the message has gone home.
Okay, so this is also, there's improvement, although most of the people, so the previous lectures have also worked. This shows that the previous lectures, the message was given to all of them clearly, and now there is further improvement in the post-test score. Next, please.
And this is the place where it has really made a big difference, that the message of where the mild and the moderate ankle breaker index, it was very well pointed out by Dr. Soumya in the lecture, and the people have taken the message from 39%, 31%, it has gone to 48%. People have taken home the message. It is really, the numbers has really increased over here. So it is really encouraging to see that the messages are going through. But I think actually some of them have climbed, because basically the number of respondents have increased, but the percentage has improved over here. Well done, Soumya.
So with this, we now move to the second talk. The second speaker of today's session is a very esteemed, well-famed foreign speaker. He's a professional with immense contribution in the field of pharmacology, experimental medicine, and cardiovascular research, Professor Dr. Thomas Unger. He studied medicine in Germany and United Kingdom. He completed his PhD at Montreal, Canada, and Department of Pharmacology, Germany, Heidelberg. He held professorship in pharmacology and hypertension research at various universities of Germany, and he also held the charge of Director of Pharmacology and founding director of the Center of Cardiovascular Research at Berlin, Germany. He is currently Emeritus Professor of Pharmacology and Experimental Medicine at the School of Cardiovascular Diseases, Maastricht University, Netherlands. I fall short of words to commend his huge contributions for the betterment of healthcare and in the field of research and innovation for medicine and hypertension and cardiovascular diseases. We welcome you, sir, and we are honored to have you for this session. And he would be making us wiser on the management of hypertension. Over to you, Professor Thomas Unger.
Thank you very much for the invitation to speak to you at your hypertension course. I think it's very important that we communicate with each other in various parts of the world. And especially in my case, since I'm now representing the International Society of Hypertension, ISH, which really has an objective to be not locally, not regionally, but globally active. And that encompasses also that we think of the higher and the lower and the middle income regions in this world, and not only the high ones where all the equipment and all the resources are available. Now, do I start with my questions now, or how is it going?
Sir, you would be showing your overview of the presentation, then there would be the pre-test, and then you can start the presentation.
Okay, so starting my presentation, you see what I would like to show you is a little bit on the management of hypertension according to the ISH Guidelines 2020. These are the newest guidelines. And they are, as you will see, they are devoted not only to the rich countries like the European ones and the American ones, the AHA, ACC guidelines, or maybe even the Japanese guidelines. They represent affluent societies. And that is completely different from the rest of the world. And so we at ISH, we thought when we do our guidelines, we want to go both sides, and you will see what I mean by that. Basically, I don't have an overview, so we could go for the questions right now.
Yes,
yeah?
Yes, sir.
And so then we just deal with that to start with, and then I continue.
Yes, sir, please. So we are done with the poll, so you can start.
Okay, now I can start.
Yeah.
Just have to see how I can move my slides. Yeah, okay. So I will start by introducing you to the guidelines that we have published last year. We have published these guidelines in the June issue of both journals, the Journal of Hypertension and Hypertension. And this was the printed versions, but also in May last year already, we have published the internet versions of these papers. So you can read them up. You can also follow them, of course, by just going to www.ishworld.com, and then you will find the guidelines as well there, and you can download them. So why guidelines for the International Society while so many countries and regions have their own guidelines published recently? You may remember, of course, and you have been introduced already by the previous talk to the ESC/ESH guidelines for the managed hypertension. There were also the NICE guidelines from the UK. Then the Japanese Society of Hypertension have their guidelines in 19 and also in 17. The American guidelines from several societies, as you can see, leading societies were ACC, the American College of Cardiology, and the American Heart Association. actually, these guidelines, the American ones, were stirring a lot of questions and fueled discussions about the value of blood pressure at which hypertension is defined. And you may remember that the Americans, now define hypertension as everything which is above 130/80. And of course, this includes then many, many more people to have hypertension than before. Actually, almost half of the American adult population, 44% under this definition, is now hypertensive. The question is, of course, what to do with them, how to treat them. And so we are still discussing. The rest of the world, so the non-US American world, they are sticking still to the, if you want, more conservative definition of hypertension, which is everything about over 140/90. Now you see that we do have a lot of hypertensive people in this world. And in certain years ago, there were estimated 1.39 billion people in the world with hypertension. And this was divided in about 350 million from the high income countries and more than 1 billion from the low and middle income countries. So we really have to focus on these countries where hypertension is developing together with these developments in the countries. So very short on the process of writing. We had, of course, to define our goal first, because all the other guidelines were already there. And if you look into the ACC/AHA or the ESC/ESH guidelines, they are well equipped with all kinds of references. They go for evidence and the current evidence, and they detail this evidence very nicely. But of course, they're relatively long, and you have to go through 130 pages. And well, we doubted whether the average doctor will do that. And so we thought we would like to be more concise. We would not like to review the current evidence again that was done by the others very nicely, excellently. But we wanted to develop a balanced, practical, realistic, and feasible hands-on proposal for global use in line with our mission of the society. It's a global mission. So we were sticking to the recent guidelines as a background. But then what is unique about the ISH guidelines, and this will go through the whole paper as much as we could do it, we defined essential versus optimal criteria of diagnosis and treatment according to resources availability in low and middle income countries versus high income settings. Well, I'm not talking today about the diagnostics. I'm not talking over HMOD because we have heard already about that. But think about it in terms of essential and optimal. What, for instance, what kinds of diagnostic procedures are possible in a place where you may not have the optimal medical background and surroundings? And not everything is available, not the machinery, not a good hospital, not a teaching hospital. You're just somewhere in a rural area, somewhere in the rest of the world. And for these people, we wanted to provide something as well. Now, let me just jump into the non-pharmacological treatment of hypertension. Of course, we all know that we have to do better in terms of our lifestyle. We all know that. So healthy lifestyle choices can prevent or delay the onset of high blood pressure and can reduce cardiovascular risk. Yes, but we all also know that lifestyle changes is very, very difficult. Once lifestyle has been established in a certain culture, in a certain region of the world, under certain climatic conditions and so on. And lifestyle modification is, of course, often the first line of antihypertensive treatment, but we all know that in many cases, it's not enough. And modifications in lifestyle can also enhance the effect of antihypertensive treatment. Yes, I'm convinced this is the case. So one should go both sides, lifestyle modification plus antihypertensive treatment. Well, the non-pharmacological treatment in a bit more detail, the diet. We all recommend to reduce salt, which probably is right. But where we discuss still, and you may have contributed to this discussion, is what is the right limitation of salt? What is low salt? What is high salt in our diet? And when you think of the papers that have been published by Salim Yusuf and colleagues, then you see that it's not that easy. So salt reduction to, let's say, below 3.5 grams per day is very, very difficult, and also may not really be as beneficial as some people think. But in general, of course, we say salt added when preparing foods should be reduced. And there should also be a reduction and avoidance of food which is high in salt. For instance, when you think of fish which is salted, think of northern Japan and so on. Eating a rich diet in whole grains, fruits, vegetables, polyunsaturated fats, and dairy products, just as the DASH diet, which is nothing else but this type of diet, the so-called DASH diet. Then reducing food high in sugar. That has become very fashionable now, and I think it's true. High sugar in food may contribute to a number of diseases, including diabetes mellitus, obesity, and also may aggravate the situation of hypertensives. Also reduce saturated fat and trans fat, especially the trans fats. That is important. Increasing the intake of vegetables high in nitrates, that is something which came a bit more recently to the diet recommendations. For instance, leafy vegetables and beetroot. Beetroot has been shown to reduce blood pressure to a certain degree. On the other hand, who will drink beetroot or eat beetroot every day in enormous amounts? So it's something which contributes, but it's kind of a by-giving. Other beneficial foods and nutrients include those high in magnesium, calcium, and potassium. And you will find this in avocados, in nuts, in seeds, and legumes, and in tofu. So there are some definite things you can do and you can recommend to the patients in terms of lifestyle modification concerning their diet. Now let's see how I can go further. Positive, yeah. So moderate consumption of healthy drinks, coffee, green and black tea, carcade, which is the hibiscus tea, pomegranate juice, beetroot juice, and cocoa. So moderate consumption may be good for you or your patients. Moderation of alcohol consumption and avoidance of binge drinking. Yeah, everybody knows that. Reduce weight and avoid obesity. Yes, difficult, very difficult in many patients, but we should help our patients to do that. And be careful with complementary alternative or traditional medicines. There's actually little or no evidence that they may be helpful. But in many cultures, in many regions of the world, these complementary alternative or traditional medicines are used. And the problem is that the doctor quite often doesn't know that the patient is using these medicines. So this requires that you really ask a proper history and you insist on asking what is this patient taking in addition to the normal diet or to the pills that you have prescribed. Smoking cessation, yes, of course. Then engage in regular moderate intensity aerobic and resistance exercise. So one of the recommendations is 30 minutes on 5 to 7 days per week or high intensity interval training. If this is possible, of course. In many situations, it is very difficult to do that because of business, stress, family affairs, and so on. But that should be done. Reduce stress and introduce mindfulness. That's relatively new in hypertension guidelines. Introduce mindfulness, and you can see what it means. And reduce the exposure to air pollution and cold temperature. That's also new in these guidelines of ISH. You will not find that in other guidelines. But it's important. If you think of India, cities in the world where you can't see the sun anymore, in China and other places in the world. And it seems also that exposure to cold temperature in the room, inside the house, is also a factor contributing to hypertension. That was not known, but some studies that have been done recently show this. So now after all that, We know that in many, if not in almost most places and conditions of hypertension, we need drug treatment. Now, the drug treatment, we had a lot of discussion about that. And I just show you here the algorithm that we follow. And in a way, this algorithm is very closely related to the algorithm of the European Societies of Cardiology and Hypertension, yes, with some slight but maybe important differences when it comes to essential and optimal. So when we have established the diagnosis of hypertension, of course, we start with lifestyle advice, as I have pointed out now a minute ago. Now let's go to the left. We have grade 1 hypertension, which in our hands is blood pressure from 140 to 159 systolic and 90 to 99 diastolic. Under essential and optimal conditions, we have immediate drug treatment in high-risk patients, or those with HMOD, like, as you have already heard, cardiovascular disease, chronic kidney disease, diabetes, and so on. So in this case, we would go for immediate drug treatment. But then we split the screen, so to speak. On the left-hand side, essential, and then in the middle, optimal. Now we come to something which is new in guidelines. If there is a region in the world where there is limited drug availability, and I mean, you would probably say, well, drugs are ample everywhere in this world, but think of the coronavirus pandemic now, that the limited availability of the vaccine is really a dominating problem. And we have to decide as doctors, as politicians, who will get what. So we have now a choice here. If there is limited drug availability, yes, then in those at lower risk, supply lifestyle intervention for 3 to 6 months. If blood pressure still not controlled, and where possible, start drug treatment in those aged 50 to 80 years. This is a form of triage, if you want. Because what happens with those below 50 and above 80? But we say, well, we have to make a decision under the assumption that there is limited drug availability. Now, if there is no limitation of drug availability, then you see the arrow, the blue arrow goes to the middle. And then we do what everybody is recommending, drug treatment in low to moderate risk patients without all the problems after 3 to 6 months of lifestyle intervention, and then drug treatment if blood pressure is not controlled. So here we really have a division between essential and optimal conditions. And in the essential conditions, limited drug availability, we do some kind of a triage. And we really, believe me, we discussed this a long time. We discussed this a lot. Now, if we have grade 2 hypertension, this is on the upper right, when blood pressure is above 160 over 100 in essential and optimal conditions, we do, of course, immediate drug treatment in all patients. So under essential conditions, the target blood pressure reduction should be at least 20 over 10 millimeters of mercury, ideally reaching a level below 140 over 90. That doesn't depend on what we are doing. We try to reach this. But under optimal conditions, then, as you have already heard from the European guidelines, if somebody is below 65 years, then blood pressure can go below 130 over 80 if tolerated, but not below 120 over 70. This is also in the European guidelines, not in the American ones, because we think then the detrimental affair is bigger than the benefit. If the patient is more than 60 years, then the blood pressure target should be at least below 140 over 90 if tolerated, but consider an individualized blood pressure target in the context of frailty, independence, and likely tolerability of treatment. So you could even go lower, but that needs to be tolerated by the patients individually. And then aim for blood pressure control within some months, 3 months, ideally. Now, being a bit more specific still, drug choice and sequencing. Let's go for optimal first on the right-hand side and then go to essential. Now, this is very similar to the NICE guidelines, to the European guidelines. Step 1, is a dual dose combination, ideally as a single pill. And this is A plus C, whereas A is an inhibitor of the renin-angiotensin system. It may be an angiotensin converting enzyme inhibitor or an angiotensin 81 receptor antagonist, an ARB. Step 2 is the full dose combination of those two. This is new. You will not find that in the European guidelines, but we thought we start with a low dose and then titrate up with these two, because in many patients with this dual combination at a high dose, full dose, we can already reach our goal. If this doesn't work, then we come in with a diuretic. So as you can see, the diuretic in our hands, ISH, is not in the first place anymore. It is not that you can just switch from the calcium blocker to the diuretic and vice versa. Now it comes in as step 3. And only then, if you have what we call resistant hypertension, then we add to this triple combination spironolactone or another drug, depending on how spironolactone is tolerated and so on, 12.5 to 50 milligram once daily. Yeah, so you see that is somehow different from what has been published before, but it makes use of the knowledge of the other guidelines. So consider monotherapy in low risk grade 1 hypertension or in very old patients or frailer patients. These are the exceptions, the two exceptions where you can really consider monotherapy. Otherwise, always combine from the very beginning and ideally optimal conditions with a single pill combination. Then we have some patients, very elderly, incipient heart failure or calcium blocker intolerance. This is also possible. And then one could actually go for A plus D. So then the diuretic would come into the first place. In Black patients, considering what is evidenced, we recommend A plus C or C plus D in the beginning. Caution should, of course, be done with spironolactone and other potassium-sparing diuretics when the estimated GFR is below 45 or the potassium is above 4.5. Yeah, I think that is optimal. Now, what are we doing with essential left-hand side? And that is different again. Use whatever drugs are available with as many of the ideal characteristics that we describe in table 9 in these guidelines. So whatever drugs, if you have paucity of one drug or if there is no ARB available or no calcium, use what you get. Use free combinations if the single pill combinations are not available or unaffordable, too expensive. Use thiazide diuretics if thiazide-like diuretics are not available. We go rather from the evidence, the present evidence, to thiazide-like diuretics. But if they're not available, why not use thiazides? And use alternative to dihydropyridine calcium blockers if these are not available or not tolerated, non-dihydropyridine calcium blockers, for instance, diltiazem or verapamil. And now we come to the beta blockers, essential and optimal both again. Consider beta blockers at any treatment step when there is a specific indication for their use. For instance, heart failure, angina, post-MI, atrial fibrillation, or younger women with or planning pregnancy. Otherwise, if you have a so-called uncomplicated hypertensive patient and you start treatment, the beta blocker is not in the first line anymore, not in the second, and even not in the fourth, so to speak, only if there is an additional reason to give this beta blocker. And this is mainly a cardiac reason, but also pregnancy. Okay, in summary then, for the drug treatment in established hypertension uncontrolled by lifestyle measures, the drug treatment threshold would be above 140/90, raising to 160/100 for those at lowest risk. So we are relatively flexible in this case. The drug treatment target, as you have already seen, optimal. If somebody is below 65 years, then we would try to go down to 130/80. Above 65 years, go down to whatever works, but it should be below 140/90. And essential conditions reduce blood pressure by whatever measures and means and drugs that you get in these conditions. But at least 20/10 reduction. Optimal conditions, you do the up titration to target of the following: low dose A plus C, then full dose A plus C, and then third, you add the diuretic, and then resistant hypertension, you add spironolactone or a similar drug. Consider other initial combinations for specific patient subgroups. We have seen that: Black patients, frail patients, cardiac problems, and so on. Use single pill combinations wherever possible, because they reduce the number of drugs, which is very important for the compliance of these patients. We all know that the compliance is reduced when you increase the number of drugs. Use thiazide-like diuretics preferentially, but as I said, under essential conditions, if they are not available or too expensive, then of course diuretics of the thiazide group are also preferred. And under essential conditions, where less ideal agents are available, focus on effective blood pressure lowering, at least 20/10. Common and other comorbidities of hypertension, we have heard already a lot about that. I just try to focus your attention on the overall problem. And this is a study by Salim Yusuf a couple of years ago in the Lancet, the Interheart study, when he looked at acute myocardial infarction risk with several risk factors. And you see they are all listed down there: smoking, diabetes mellitus, hypertension, lipid problems, all four. Sorry about that. All four are obesity or psychosocial problems, or all. Now, what is important when you look at the red line? Sorry about that, telephone. When you look at the red line, you see that 1, 2, 3, that is smoking, diabetes, and hypertension, already increases the risk of myocardial infarction a lot, whereas these as single factors are relatively low, let's say between 2 and 3-fold increase. Now, if you add lipid disturbances, all four, you're already at a risk increase somewhere between 32 to 64. And so it goes. And if you have all these risk factors, then you have a tremendous increase of risk. We'll say that we have to look at the others as well, not only at hypertension as shown here with the red arrow. Right, and this is a kind of a modification of the picture that you have already seen, where hypertension is put into relation with risk factors. Now, I'm not going through these risk factors again, you have heard about them, but just the therapeutic consequences. Let's say we have a patient whose blood pressure is 178/106. Well, we agree this is hypertension and should be treated. Now, our goal is below 140/90. And we do this by drug treatment, and we end up in the green area with 138/86. Fine, we have done our job, good. Now, unfortunately, many patients are not there in the yellow range, they're in the red box. That is, they have 3 or more risk factors, or they have TOD, which is HMOD, actually diabetes and so on. Now, these patients are in red. Now, when we actually treat them to below 140/90, they're still in the red box. So we have to do something. We either have to change our goal and go below 130/80, and you see that, then we get them into at least dark yellow. And we have to do something in addition. That is strict blood pressure control plus trying to reduce the other risk factors. So hopefully we get this patient back into the green box. But it tells you that blood pressure reduction alone doesn't help, is not enough. If the patient is in the red box, that is, if he or she has already a lot of complications. Now, one of those additional comorbidity concerns the rheumatic disorders and also the psychiatric disorders. They are also a bit neglected by the other guidelines, but many patients, especially the elderly, have some rheumatic disorders, and then they take a lot of NSAIDs like ibuprofen. And one should be aware as a doctor that there is interference with antihypertensive drugs. For instance, RAS inhibitors don't work that well if NSAIDs are given chronically at the same time. Yeah, and psychiatric disorders. Well, how many patients do we have who get all these terrible drugs that work in the brain, the antidepressants and the neuroleptics and whatever, and the tranquilizers? And some of them get really orthostatics, especially if they take the serotonin reuptake inhibitors. And if you then give them a calcium blocking drug, right, as we show on the guidelines, then we may have a problem with these patients. So I just want to focus your attention a little bit on these often forgotten diseases that go along with hypertension, but are not really cardiovascular or metabolic related to hypertension. So we forget about them, but patients don't, and they get the drugs. Now, a few words about resistant hypertension. Consider changes in the diuretic-based treatment prior to adding the fourth antihypertensive medication. Add a low dose of spironolactose. Consider amiloride, doxazosin, eplerenone, clonidine, and beta blockers as alternatives to spironolactone. If unavailable, consider any antihypertensive class not already in use. Optimally, consider referring to a specialist center with sufficient expertise and resources. But again, this is under optimal conditions and may not happen in many areas of the world. In secondary hypertension, very short, consider screening for secondary hypertension in early onset hypertension, resistant hypertension, sudden blood pressure control deterioration, hypertensive urgencies and emergencies, high clinical probability of secondary hypertension under these conditions. Exclude pseudo-resistant hypertension and drug or substance-induced hypertension prior to investigations for secondary. Pseudo-hypertension resistant is quite often the case if patients don't take their drugs, for instance, and this happens. And drug substance-induced hypertension, well, there you really have to look into that, then scrutinize. Does this patient take things that could increase blood pressure? And we do not know as doctors about that. So under essential conditions, you do a basic screening for secondary hypertension through history, very important, physical examination, plus basic blood pressure biochemistry. And we settled there after discussions. We included serum sodium, potassium, then the estimated GFR and TSH, plus dipstick urine analysis. This is kind of the basics that should be done under all conditions to screen for secondary. And under optimal conditions, of course, you can arrange other investigations for secondary hypertension, additional biochemistry, imaging, others based on information from history, physical examination, and basic clinical investigations, and or, if feasible, refer to a specialist center. Finally, a word on ethnicity, race, and hypertension. Again, ISH is a globally acting hypertension society, so we have to take care of different ethnicities, races in different countries of the world. So the prevalence and treatment control rates vary a lot between the countries according to ethnicity. And this is mainly attributed to genetic differences, black and white, and so on, contextual and cultural practices like lifestyle, socioeconomic status and differences, health behaviors like diet, alcohol, and others, access to health system, yeah, I mentioned that, and availability and distribution of essential drugs. So, and just in Asia, populations from Asia have, according to the evidence, more morning and nighttime hypertension versus Europeans. East Asian populations have a likelihood of salt sensitivity increased and mild obesity in hypertensive patients, have an increase of stroke prevalence, especially hemorrhagic stroke, which is rather rare in other populations, and non-ischemic heart failure versus Western populations. In South Asian populations, Indian subcontinent close to you, so then the risk of cardiovascular and metabolic diseases is higher. For instance, diabetes or coronary artery disease. Well, having said all that, what is the consequence for the management of hypertension in South and East Asia? Well, at the present time, we have to confine ourselves to standard treatment until more evidence becomes available. That's a bit sad. I would like to have more personalized, individualized treatment for Asian versus, let's say, European populations. But at the present time, there is no evidence for that enough. And finally, let's go through the final slide, which is hypertension management at a glance, which is also new in our guidelines. We have two of these tables. One is the green one for essential, and then you will see the blue one. I'm not going through all of what is on these tables. I just want to say that if you look at them, you have hypertension management at a glance. You can see what to do with these patients, evaluate diagnosis, evaluation, treatment, monitoring. And this is under essential conditions where not everything is available, and we have discussed that. For instance, non-Black patients versus Black patients and so on. And then under optimal conditions, again, the same thing. Diagnosis, evaluation, treatment, monitoring. So under both conditions, wherever you are in this world, so to speak, just one glance at one page on these guidelines will tell you what the recommendations are and what to do. And this again is the two papers that have been published, as I mentioned in the beginning last year, but you can also refer to the homepage of ISH, as you see on the bottom on the right. And this brings me to the end. Thank you very much for your attention.
Thank you so much, Professor Thomas, for such an enlightening talk. It was indeed very enlightening for all of us. Can we have the post-test poll?
Seems to be a long decision process. Yeah, okay.
Professor Thomas, could you comment on the post-poll evaluation?
We will do this once we have all the data together, sir.
Mm-hmm.
I think our post tests are done, And while the IT department sort of compares them up, or built it up, Professor Thomas, may I thank you for taking the day out and joining us in the early morning from Germany for such a lovely presentation. A few questions are that I would like you to sort of look into it and give us what's your intake on it. You very nicely did point out that yes, smoking is something which is makes a big difference. But now the current trend with the cigarette manufacturers is that they are trying to push the e-cigarettes, the rich man's smoke, even to this lower income area. So I'd like to have your comments regarding the e-cigarettes and the hypertension. Then you also pointed out about we must need to take the history very carefully. And a lot of these people over here and around the world love to take vitamins. And what is your take with vitamins abuse or usage excessive, and how does it affect the hypertension? Then anecdotal facts at times come up that people who have got are in their elderly age group and are not on any antihypertensive treatments, but are maintaining a blood pressure of 105, 65, something like that, below the 120/80 range. So are they at any higher risk than those who are being maintained? Because a lot of these questions always come up. And you especially very nicely pointed out about the fact that we have to look at the low income situations where people can't afford treatment or the drugs are not available. Now, keeping this fact in mind, we can provide treatment within $1 for the whole month by prescribing a very cheap beta blocker and a diuretic. So where will your take be in a situation where it is essential to do something and you are giving a drug which is no longer in your 1, 2, 3 guidelines? And finally, regarding the diabetes part, it is one of the known risk factors, but if a person has been maintaining HbA1c consistently below 6.5 for 5 years or more, can we actually start thinking that this person's one risk factor is no longer? Just, these are the things that always keep on creeping up.
Okay. Five questions.
Yeah, that was things that I thought that everyone asked.
Starting with the smoking. Smoking, of course, is one of the worst things that people can do to themselves. We know that. But not all, actually. I know people who became 95 before they died and they smoked like hell. There is a lot of genetics also involved.
Yeah.
And you can see that even running in families, in family traits, that some of these members smoke and have nothing in their coronaries and lung, and others have it very early. So, but smoking, we agree. Now with the e-cigarettes, there is just not enough evidence available so far that can tell us whether they are kind of harmless, or I would say, I mean, if somebody smokes a lot with them, there may be also some nicotine getting into the body. It's like when you may remember when it came to the comparison between cigarette smoking and pipe smoking. And there was this kind of philosophy, well, cigarette smoking is dangerous because of all those ingredients in the cigarette, and pipe smoking is just the tobacco and is not so dangerous. But then if you're a pipe smoker, you take up a lot of nicotine through the mucosa to the mouth, and actually you have a real load of nicotine then also. And nicotine by itself is also dangerous. So again, we don't have enough evidence so far. The second question, vitamins or vitamins. Yes, I mean, there are lots of studies with vitamin C, with vitamin E, D. Vitamin D seems to be something which is now in the focus, and maybe there is something behind it in the cardiovascular field. We have to wait and see. Vitamin E was used in large studies and did not show any beneficial effect as compared to real drugs, so to speak. And vitamin C, yes, I mean, that is something that people should take anyhow enough to avoid scorbut and other things.
Any chance of an overdose side effect?
Overdose side effect, yes,
Yeah.
you may have some problems in the kidney, but yes, it depends on the individual very much and really on the dose. And I think a reasonable dose of additional vitamins will not harm you, but it in many cases will also not help. Then low blood pressure and the risk. Well, I mean, usually we say the lower the better. And we also say this for treatment and management of hypertension, the lower the better. But one has to say that these recent analyses by Peter Slide from the on-target study, by Verdecchia, by others, they show that in terms of stroke prevention, this is true. In terms of stroke prevention, you can go as low as you want and you still have less stroke, especially ischemic stroke. In terms of cardiac problems, myocardial infarction, it doesn't seem to work that well. And there seems to be a turning point at 130, systolic. And so that makes us think about a J curve, if it exists. This is discussed, as you know. But anyhow, this is why we do not recommend blood pressure control below 120/70. And this is also in accordance with the European guidelines, not in the American guidelines. Because if you go below that, you may have a problem with the coronaries, with the diastolic perfusion and so on.
But if a person is as such normally without any drugs and
sir,
is maintaining the pressure, just a second, I will just finish this one up, and is maintaining the pressure at 110 or 105, is this person at risk without any hypertensive? That's the trick question.
I would say no.
That's what I thought.
I would say no. I think this person will have a long life.
Well, we have comments from Professor Shehbaz Qureshi.
Just a second, he has to answer two questions at the moment.
I have to answer two questions.
Okay.
Now, the cheap beta blockers plus diuretic treatment, that goes along exactly with what we want to get through, that is under essential conditions. Yes, please go for it. Go for a diuretic and a beta blocker if you have nothing available according to our recommendations. But if the drugs that we recommend and the scheme we recommend, practically in all guidelines, is available, then go for that. So it really distinguishes between optimal and essential conditions. And diabetes 6.5, yes, we settled for 7 actually. We say, well, we start at 7, but 6.5 over years is still subdiabetes. And we do not take this under consideration as diabetes as such, as a disease. But that is arbitrary. Yeah, you could also go for 6.5 or 6.4.
Yeah,
it's arbitrary. Yeah. Okay.
Okay, post-test now, please.
So next question.
Now we are going to the post-test comparative analysis.
Oh yeah, the polls. Yeah. Can I comment on them?
Yes, please. You do. That's your part. Right?
So in the beginning, 62% that said that International Society is the only one which does that, which is correct. Yeah, 82%. And this is really a learning effect. Next one.
Next.
Yeah, there is also a learning effect here. Of course, the first answer, optimum weather for blood pressure measuring, is just a joke. Essential conditions for blood pressure treatment, high income countries, no, this is not what we think optimal versus essential is, but optimal resources in high income versus essential resources in low to medium, this is the answer. And it went from 58 to 77, so there was certainly a learning effect there. Yeah, that is a problem here, because I deliberately put things together which are partly healthy and partly unhealthy. if you go for polyunsaturated fats, that's good. High sugar is bad. High nitrate vegetable is good. But this combination is not to recommend because of the high sugar. Then when you go for whole grains, trans fats and green vegetable, well, what sticks out is the trans fats, which you shouldn't take. Then we come to high nitrate vegetables, fine. Healthy drinks, fine, but not salted fish. There's too much salt. And finally, vegetable, nuts, and polyunsaturated fats, yes, but there was no learning effect. So look into the guidelines. Under essential conditions, blah, blah, blah. No, the next one, is there one? There's one more, I think. Yeah. Under essential conditions, beta blockers are indicated in women planning pregnancy, yes. That's what I said and what I pointed out. Never use non-dihydropyridine calcium blockers. No, if others are available and you are not tolerant to dihydropyridines, take the others. Try to reduce blood pressure by 30/15. Well, that would be great. But what we say is at least 20/10. And I've mentioned that 2 times. Use never a free pill combination. No, I mean, never use a free pill combination. Under essential combinations, you can do whatever you want to reach your goal. Free pill combinations, yes. Why not? I think those were the questions.
Can we take one question from the attendees before we can go to the concluding remarks by the chair? Because we are running short.
Professor Shabazz has his hand raised, so I'll say we go for Professor Shabazz first.
Okay.
Thank you very much. I think Professor Thomas gave us an excellent lecture. The lecture from Dr. Somia also was excellent. Unfortunately, I could not make the comments at that time, but that is now a past event. Professor Thomas, you talked about salt. In our part of the world and in South Asia, in the Far East, people are very salt sensitive. And I think it's very important that salt should be reduced. Your comments on that. And the second part of your presentation was about drug treatment as far as the essential component is concerned. Number one, that in stage 1 hypertension, you would like to continue with lifestyle management. And then if the age is between 50 to 80 years, start with drug treatment. My point here is that if hypertension is starting early on, like at the age of 35, 40, and continues for the next 15, 20 years, already there will be hypertension mediated organ damage. And I think to delay the treatment would not be the right thing to do. That is the second point I like to make. And thirdly, I'm sure that the guidelines, when they were being written by the International Society of Hypertension, there was a lot of effort put into it. But when we talk about the essential treatment, and when we say that we should bring down the blood pressure by 20 millimeters systolic and 10 millimeters diastolic, at least, what would be your take on a patient who is 210 by 120, and you bring down the blood pressure to 180 by 110? Is that going to be enough for that patient? Because he's still hypertensive and you're going to need treatment for that patient as well. Mm-hmm. Then in all patients who are
can
hypertensive,
we just take these comments because we are running short of time?
Just the last point. In all patients with hypertension, you have chronic kidney disease. And if you are having resistant hypertension in these patients, you will not be able to use spironolactone. What would be your recommendation in such a patient? Mm-hmm. Should potassium binders be used and then spironolactone can be used in these patients to reduce hypertension? Mm-hmm. Mm-hmm. Thank you very much.
Mm-hmm. Yeah, you started with the salt questions. I try to highlight it from both sides. Certainly in salt-sensitive people, salt reduction is important because salt can increase blood pressure in salt-sensitive people. We know that. And it's actually only sodium chloride. It's not sodium bicarbonate or other combinations, only sodium chloride. The question is really, twofold. First, can we actually define this subgroup of salt-sensitive people? There have been attempts, as you know. And second questions, what is actually the threshold? What is the level at which we should interfere, reduce salt, and to which level should we reduce it? And there's still a lot of discussion on that. So I'm not going into detail, but I would say, yes, a moderate salt reduction is good anyway. And especially in populations where you have a high population of salt-sensitive people. Hypertensive, in the others, it doesn't matter. Now, then the next was lifestyle and drug treatment. Yes, my personal opinion, but I'm a pharmacologist, so to speak. I'm going for drug treatment right away. But in all guidelines, we have to include the lifestyle things, at least give it a try. And hypertension is a lifelong disease. So if you do 3 months of lifestyle improvement or even 6 months, you still have a lot of time to do drug treatment later on. Then the blood pressure, yeah, if a patient, yes, if a patient has 220 over 120 or something like that, yes, of course, you have to do everything what you can to get this patient below 140 over 90, whatever you can. This 20 over 10 is only a guideline, you know, in many patients where they are somewhere between 155 and 60 and something, try to get them below 140. But in the real severe hypertensive patients, especially if they run into a hypertensive crisis and so, whatever is possible. And finally, spironolactone replacement in kidney disease. Yes, it's a problem in resistant hypertension with kidney disease. But what we say is in the guidelines, you can try, if spironolactone is contraindicated or not tolerated, try whatever drug you haven't used before, whatever class. You know, you can use an alpha antagonist, or you can do beta blockers. Or you may do even eplerenone, which might be better than spironolactone in this case. So this is open, but you can use any class of drugs which you haven't incorporated in the first 3, including a diuretic.
Thank you, sir. Before we can conclude the session, as we are running short of time, I would request the chair of the session, Professor Dr. Akbar Chaudhry, to give his valuable concluding remarks.
First of all, let me thank
Akbar Sahab, you have gone mute. Akbar Sahab, you need to unmute. Many Dr. Zulfikar and Dr. Naeem Toor are also.
Can you hear me now?
Can you hear me
now? Yeah. First of all, let me thank Professor Thomas for joining us in this session. It was a wonderful talk, and he summarized the guidelines very nicely. He put these things into 2 categories, essential and optimal, and I'm sure that many of our patients who are non-affording and due to various reasons, so we can adjust that treatment according to the essential component of this talk. Similarly, we can modify according to the pocket of the patient. We can tailor the treatment accordingly. Other thing is that first we have to try the non-pharmacological intervention, and in the mild cases. But if that does not work, then of course we have to go to the medical treatment or the medicines. Some patients, if they are not responding to the treatment, in those patients we must review whether the patient actually is taking treatment, and if he is taking treatment, whether he is taking according to the prescription, whether he is taking as times as we have prescribed, and if in spite of that, if the blood pressure is resistant, it appears to be resistance, then one has to think of that there could be secondary cause, or the patient may be taking antipsychotics or non-steroidal anti-inflammatory drugs or steroids, as Professor Thomas has already mentioned. So with these remarks, I will thank all the participants, and especially Professor Thomas, who joined us from Germany. Thank you very much.
Thank you, sir. It was a pleasure and an honor to have you as the chair of the session.
Marine, if we can take on Dr. Zulfikar Ahmed, he has his hand raised. I think he needs to have.
Sir, we are already okay.
I think one question. You can have one question. Dr. Zulfikar.
One question.
Dr. Zulfikar, are you still there? We had one Dr. Zulfikar and Dr. Mohammed Naeem with questions first. Dr. Zulfikar, are you still there? Well, it seems that he is no longer, so I think then we
he's
can,
not there.
Yeah.
So I would just conclude by thanking all the participants, the worthy chair, our foreign speaker, Professor Thomas Unger, Dr. Somia Iqtidar, brilliant speaker, and all the panelists as well, and the corporate pharma that made it possible and made it a success to run this whole session smoothly and uninterrupted. Thank you so much. Thank you everyone for an enlightening session.
Thank you and goodbye and thank you for all.
If I could just take a minute. Thank you, Professor.
Yeah,
and I just have to make a small announcement about our international second annual conference, which is going to be held on 30th and 31st of July and 1st of August in Islamabad, Pakistan. All of you are welcome to join us in Islamabad. The registration is open. Please register as soon as possible. And I hope to see you all there because we have a brilliant program, academic program lined up. There are some pre-conference workshops. There is second fellowship convocation of Pakistan Society of Internal Medicine, along with the exciting Pakistan Society of Internal Medicine Research Awards. So hopefully all of you will be joining and registering with us, and see you all in Islamabad on 30th of July.
And hopefully we'll be able to bring Professor Thomas, and if the moment this COVID business.
If Professor Thomas wants to join, it will be an honor for all of us to have him and have a talk from him. I don't know what are the travel restrictions for Germany, for Pakistan.
At the moment they are there. At the moment they are there.
No idea right now. It changes.
At the moment they are there, and we are hoping that things will improve in September.
Yeah.
But anyway.
Thank you very much, Dr. Mehreen, for your brilliant moderation as always. When Dr. Mehreen is in charge, I am very comfortable because this program is going to be running smoothly. Thank you very much.
Thank you, Somya, for the kind words. Thank you. Have a good day.
Thank you all and have a great day.
Thank you. Allah Hafiz. Allah Hafiz.
Allah Hafiz.